Good afternoon, all. Welcome to the WDC webinar of IDA Malabar. So today's topic is on minimal aerosol pediatric dentistry. So before that, let me introduce myself. Myself, Dr. Sherin, and I'm working as an assistant professor in the Department of Periodontics and Preventive Dentistry at Sri Anjaneya Institute of Dental Sciences. So I'll start with my screen sharing now. So, as I said, today's topic is about the minimal aerosol pediatric dentistry. So, we all know over the past few months, our focus of interest was more towards the new emerging the pandemic, the coronavirus infection. When it was first diagnosed, actually we had no clue about what caused this infection, what was the main problem with this infection, how it was transmitted, what are the various modes of transmission. We had no clue regarding all those things. So but as we got to know more about the virus, we get to know the importance of staying at home, the importance of wearing a face mask while you're going to any public space, the importance of proper hand washing, the importance of maintaining social distances and all. So as time went on, now we know what all we need to do to prevent this pandemic, to prevent the catching infection of this coronavirus. So we have guidelines that have been set by the World Health Organization, Center for Disease Control, UNICEF, the American Dental Association, the American Association of Pediatric Dentistry, etc. So now we actually know how can we protect ourselves from the new coronavirus infection. Now, let's know. Now, actually, most of us have started emergency cases in our clinics, and it is actually time for us to welcome the kids back to the department. Or when the kids are coming back for the clinic, there are certain recommendations and guidelines that you have to practice so that you can minimize the production of aerosols in your clinics or your colleges. So, Royal College of Surgeons, it has set up certain recommendations for pediatric dentistry during the special COVID-19 pandemic. So, Royal College of Surgeons, they have listed few treatments as the urgent dental care, or few treatments or few conditions in the child require emergency management. So, they are, first one is the presence of a swelling. Any swelling that is compromising a swallowing or breathing or causing trismus or significant oral and facial swelling is listed in the urgent dental care during the special pandemic scenario. Similarly, the second case is about the traumatic dental injuries. So, traumatic injuries occurring in the primary tooth or in the permanent tooth, which may include either avulsion injuries, or it may be due to severe luxation injuries or a complicated crown root fractures. So, these two are listed in the urgent dental care. Thirdly, you have uncontrolled bleeding. If you see an uncontrolled bleeding in a child that has not responded to any self-care measure, that requires an urgent management. Now, the fourth scenario is a severe dental pain of pulpal origin, which has not responded to over-the-counter analgesics and is impacting on the eating and sleeping habits of the child. So I repeat, these are the four things that cause urgent dental care. You have swelling, a huge swelling that is causing trismus or causing difficulty with swallowing and respiration. Secondly, you have traumatic injuries in either in the primary tooth or in the permanent tooth. Then you have uncontrolled bleeding. And the fourth one is the severe dental pain due to irreversible pulpitis. Also, when you're delivering this urgent dental care, another thing that you have to take care is that there are certain priority listing. You priority of your treatment should be given to those children with underlying medical conditions that increases the risk of complications of the child. That is the first priority that you have to give to. Now, the second thing is a child with any additional needs. That is a child with a learning disability or an autistic child. If pain is impacting on this kid, it would even affect the family. So a special child or a compromised case is one thing which you need to know, which you need to give more priority to at this time period. Now, the third priority should be given to an increased risk of bleeding from either a medication or a condition that may be due to a chronic renal failure, liver failure, or any other bleeding disorders. Now, the fourth priority is given to an increased risk of infection that may be due to an immunocompromised state, a patient on steroids, a patient with a risk of infective endocarditis, or a transplant patient. So these are the priority that we should give during this particular urgent dental care management. Now we'll move on to a topic that is an aerosol-free dentistry. So most of my slides will be covering through the guidelines that has been given by the Indian Dental Association. So as we move on towards an aerosol-free dentistry, first we need to know what is an aerosol and how dangerous it could be. So aerosols are actually particles that are less than 50 micrometers in diameter. So as they are very small enough, they can stay airborne for an extended period of time before they settle on the environmental surfaces. That is, an aerosol can stay airborne for an extended period of time before they settle on the environmental surfaces. So now we'll see how COVID-19 is transmitted through these aerosol particles. So we all know most of the respiratory infections, they are transmitted through our cough, sneeze, etc. But they are actually large droplets. So they have got heavy mass. Because of that heavy mass, they would easily settle down at a smaller distance. But what happens is that when a viral particle is aerosolized by either your cough, sneezing, or your dental treatment, what happens is that these aerosolized particles, they can travel up to a larger distance of even up to 20 feet. So it has the potential to cause infection at the from its site of origin to a further location like around 20 feet. So that is the importance of this aerosol transmission, which we need to understand at this typical scenario. That is, being aerosols, as I've already mentioned, they can stay airborne for a longer period of time and before they settle on the environmental surface. So when a viral particle is aerosolized, it can travel up to a further distance of around 20 feet and be infective at that site too. So that is about the COVID-19 transmission through the aerosol particles. Now, this is the picture of a visible aerosol cloud that is produced from an ultrasonic scale, and this is from an air rotor. So, for us, it would have been definitely a small streamlined jet of water. But what happens is that you can see here in this image, it is very clear that how much of aerosols are produced from these two instruments alone. So it is very important that in the special infective stage scenario, we should try our best ways so that we can reduce the amount of aerosols that is produced from the dental operating site. So we'll move on to the sources of airborne contamination during the dental treatment. Basically, there are three sources of airborne contamination during the dental treatment. One is from the dental instrument itself. The second is one from the saliva and other respiratory sources. And the third is from the operative site. So, dental instruments. So, or any organism, if it is left on the instrument and if it is aerosolized, definitely it is a source of airborne contamination. But this is one part of the source of airborne contamination which we can actually control, because if we are following a routine cleaning and sterilization procedure, this problem we can easily overcome. So if our instruments are properly clean, we don't have to worry about the airborne contamination resulting from our dental instruments. So the first source is dental instrumentation. Now let's move on to the second source. Second source is the saliva and respiratory sources. So as we all know, saliva is a pool of microorganisms. You have a lot of bacteria in your saliva, in your supragingival plaque, in your periodontal pocket, your subgingival plaque, and yes, mouth has the pharyngeal secretions that is coming out. Again, that is rich in microorganisms. So we should keep in mind that any dental procedure that has the potential to aerosolize saliva can cause airborne contamination with organisms. That is, any dental procedure which has the potential to aerosolize saliva can cause airborne contamination with organisms. Now moving on to the third source of airborne contamination, that is the dental devices that produces airborne contamination. So as we all know, our ultrasonic and sonic scalars, they are considered to be the greatest source of aerosol contamination, but this can be controlled to a minimum level with the help of a high volume evacuated tip. Now, the second dental device that is known to produce airborne contamination is your air polishing devices. Thirdly, you have your air water syringe or your three-way syringes. Fourthly, you have your tooth preparation with air turbine handpieces and tooth preparation with the help of air abrasion. So these are the main dental devices and procedures that are known to produce airborne contamination. Now let's move on to the methods of reducing this airborne contamination. So first method is definitely your barrier protection. So that could be either your N95 mask or your face shield or your personal protective kits, your surgical gloves and all. So all these, they act as a barrier in reducing the airborne contamination. Now, the second method suggested is the pre-procedural rinse with an antiseptic mouthwash like a chlorhexidine. The pre-procedural rinse with an antiseptic mouthwash will reduce the bacterial count in the mouth, saliva, and air. So that is the main advantage of a pre-procedural mouth rinse. Now, the third method of reducing airborne contamination is your high volume evacuator or your high volume suction tip. So when we use a high volume evacuator tip, that will reduce the amount of bacteria in the air, and that will remove most of the material that is generated at the operative site, such as the bacteria, blood, viruses, etc. So this is the third method of reducing airborne contamination. Fourthly, you have your HEPA filters, that is the high efficiency particulate air room filters, and your ultraviolet treatment of ventilation system. So these are the methods that are used in reducing airborne contamination due to aerosols. Now we move on to the general instructions that has been given by the Indian Dental Association. So the first thing is the use of a clinical micromotor handpiece without water or irrigation. So whenever you need to go for a tooth preparation, or whenever a cavity preparation or cavity preparation means of caries control is needed, you're always advised to use a clinical micromotor without water or irrigation. If other than clinical micromotor, the second option is your electric driven motor without water and with friction grip burrs. Electric driven motors, they have got a very high torque value, and they can be used with minimal aerosol production. So whenever you need to go for a tooth cavity preparation, your instrument of choice should be a clinical micromotor or an electric driven motor without irrigation. So when you're using these two things, there are other three things again which you need to take care of. The first one is that you should give intermittent breaks while you're doing the tooth preparation. Whenever you're working with the tooth preparation, you take intermittent break and you spray small quantity of water in a syringe to cool the temperature of the tooth down. Because we all know, if we are working without an irrigant tip or a coolant in your micromotor hand pieces, that would ultimately lead to your pulpal damage. So in order to avoid that, you should give intermittent break and you cool the surface of the tooth by sufficient irrigation. Another thing that you should take care is your high volume suction. So high volume suction, as I've already mentioned, when you use a high vacuum suction tip, it will take out most of the microorganisms, your dental materials that are generated at the operating site, and thus you can minimize the aerosol produced. Now the third one is regarding your rinsing and spitting. You should avoid rinsing and spitting to prevent the spread of infection at this particular time. Now moving on to the next general instruction, that is regarding the operating position of the clinician. A clinician should be operating from 11 o'clock to 12 o'clock plus position. This is to avoid the direct face-to-face contact with the patient. So a clinician should be operating from 11 o'clock to 12 o'clock position preferably to avoid direct face-to-face contact with the patient. Then it is advised and it is better if you could use magnification. If you could use magnification, that will enable you to maintain a safer distance from the patient. So magnification is another recommended thing to prevent aerosol contamination. Then another thing that you can do is that you can reduce the air pressure on the three-way syringe to a minimum. When you are reducing the air pressure on the three-way syringe to a minimum, you can prevent any aerosol production while drying. Finally, the most important thing is use of a rubber dam. Whenever you have to go for a restorative or an endodontic treatment, always keep in mind that you should use a rubber dam. Now, moving on to the procedures that are to be completely avoided during this time period. So, the procedures that are completely avoided are your full coverage crowns, which require extensive reduction of the tooth. The second thing is your crown and bridge restoration. The third thing is your scaling and ultrasonic devices. So, as you all know, full coverage crowns, they require extensive reduction of the tooth. So that will lead to generation of more aerosols. So during this particular scenario, you are advised by the Indian Dental Association to completely avoid full coverage crowns, crown and bridge restorations, which are comparatively less common in a kid, as well as scaling and ultrasonic devices. Now, moving on to a pedo specialty. As we all know, pedo covers a lot of things, like you have preventive aspects, you have a restorative aspect, you have endodontic treatments, you have orthodontic treatments, you have surgical treatments, and you have periodontal treatments. So pedo is one thing that covers all the aspects of dentistry. So the first and foremost thing in pedo is definitely your cariology and your restorative part. So we'll start up with the cariology part. So as we all know, in this modern scenario, whenever a child comes to us, or whenever you have any tooth with a decay, the first thing is not definitely your conventional caries management with a aerotor or a micromotor. Nowadays, in the modern management of caries, you need to assess a lot of things. That is the age of the child, the dentition of the child, the assessment, the other assessments of the child, your caries risk assessment, and you maintain a balance between all these things, and then only you will decide whether you go for a preventive intervention or a restorative intervention. So before going to the treatment planning of the child, you need to think about a lot of things. So, as we all know, caries can be of different types. Sometimes it could be a deep stain, pit, and fissure, or it may be due to or it can be a cavitated lesion, or it may be a moderate lesion, or an extensive or a grossly decayed tooth. So, depending upon the extent of the lesion and the severity of the lesion, the progression of the caries, your treatment varies. So, your treatment may vary from no treatment to your remineralization approaches, or your ways of arresting the caries, placement of a sealant, your conventional cavity preparation, or even endodontic restorations, and ultimately, if no other treatment is working, you could even need an extraction. So first we will deal with incipient lesion, and actually incipient lesions are those lesions which we can easily manage without much of an aerosol generation. So incipient lesion is the first evidence of caries in a tooth, and most likely it would be a white spot lesion. So the treatment options for incipient lesions include your remineralizing agents. So remineralizing agents, they are generally classified into your fluoridated agents as well as your non-fluoridated agents. So fluoridated agents, you know what happens with the fluoride application. So when fluoride acts with the hydroxyapatite of the enamel, it would form fluorapatite, that is more resistant to decay, and it also reduces the acid production by bacteria. So that is the main action of fluoride onto the tooth surface. It makes the tooth resistant to decay. Now, when it comes to fluoride, you have various modes of administration of fluoride. You can either advise a tooth brushing system with a toothpaste, or you have fluoride gels, you have fluoride varnishes, and that is, fluoride is one thing which has different forms of applications. So most of us actually will be having a doubt whether a fluoridated toothpaste is indicated for a kid that is less than 3 years of age. Yes, it is advised. We have the guidelines by the American Academy of Pediatric Dentistry, and it suggests that you can use a fluoridated toothpaste of size like a smear or a rice size amount without causing any risk of fluorosis in the kid. And if the child is of the age 3 to 6, you can use a pea-sized amount of toothpaste is appropriate for a child without causing any risk of fluorosis. So these are the two things that you have to keep in mind. If the child is less than 3 years of age, you can go ahead with a smear or a rice-sized amount of fluoridated toothpaste. And if the child is from the age group 3 to 6, you take a pea-sized amount of fluoridated toothpaste. So the next form of fluoride application is your fluoride gel. So fluoride gel, you apply it with the help of certain foam lined trays. So we have different gel forms available. You have sodium fluoride, you have acidylated phosphate fluoride, you have stannous fluorides that are available. So one major thing about fluoride is that most of this topical fluoride gel application, it requires 4 minutes of application onto your tooth surface. There are certain agents like 60-second paste which require only the placement of fluoride gel for 1 minute, but most likely you require fluoride gel placement for around 4 minutes. One major drawback of fluoride gel is that when fluoride gel is in contact with the tooth surface, it about within few days itself, you can see that about two-thirds of the fluoride two-thirds of the fluoride that is acquired by the enamel will be lost. So we will have only a few amount of fluoride that is reacting with the hydroxyapatite to form the fluorapatite. So that is one major drawback of fluoride gel. So in order to overcome that drawback, your fluoride varnishes were introduced. So fluoride varnishes, they require minimal application time only. Mostly it may take around 1 or 2 minutes. And what a fluoride varnish is beneficial in that it has got a protective covering. So because of this protective covering onto the tooth surface, what happens is that the fluoride that is present in the varnish that is available for a longer period of time, that could make your tooth more resistant to decay. So that is the advantage of a fluoride varnish. Now, the next thing is your GC tooth mousse. So GC tooth mousse is a non-fluoridated variant, and I'm just including it here so that you'll get a better idea of how to apply a GC tooth mousse onto your tooth surface. So what you have to do is that you squeeze a small amount of GC tooth mousse onto your finger, and then you apply it all over the tooth. If it is a young child, you only apply it with your finger, or else if you can ask your child to spread it all over the tooth with the help of their tongue. Another thing that you have to note is that for maximum benefit, you have to leave the GC tooth mousse onto the teeth surface for a minimum of 3 minutes. So like any fluoride application, the instructions that you give at the end of the application is that you can expectorate, rinse or swallow the remainder, but do not eat, drink for the next 30 minutes. So that is one thing which you need to know. You should not eat or drink for the next 30 minutes. Now moving on to the another agent, that is a CLINPRO tooth cream. One thing I forgot to tell is that fluoridated GC tooth mousse has also got a fluoridated variant that is called the GC tooth mousse plus. Now moving on to the CLINPRO's tooth cream. CLINPRO's tooth cream is actually a sodium fluoride based agent, but it is just similar to like that of any other toothpaste. That is, you take a pea-sized amount onto your toothbrush, you brush it for around 2 minutes, and then you rinse and spin. It is similar to a normal brushing system. But it has got an additional sodium fluoride content that will help to prevent decay. So these are the commonly available remineralizing toothpaste for children. So you have Kidodent, Amflor, and Pediflor. These three are fluoridated agents, and then you have Inafix too. Inafix is a non-fluoridated variant. Now moving on to the next set of caries, that is the pit and fissure caries. So as we all know, whenever there is a deep pit and fissure, what happens is that any food particles that is left on the pit and fissure, it is difficult to clean it off. It can be an easily it is this location will make it more prone to plaque accumulation and progression of caries. So in order to prevent that, you use pit and fissure sealants. Now, most of the pit and fissure sealants in the brochure, they require the application of only they do not mention about a mechanical tooth preparation, but various studies have shown that if you could do an enameloplasty or a fissurotomy, what happens is that you can increase the surface area onto which your bonding agent and your pit and fissure sealant could easily penetrate into. So whenever if you're doing a minor preparation on the pit and fissures, the main advantage is that it would increase the retention of the sealant onto your tooth surface. So that is about pit and fissure sealants. So as we all know, pit and fissure sealant is one procedure which you can easily do with minimal aerosol generation. Now moving on to the conservative management of a caries lesion that is not involving the pulp. So the first agent that we prefer is your silver diamine fluoride. So as we all know, silver diamine fluoride, as the name indicates, it's a combination of three agents. You have silver, you have diamine, and fluorides. So the main function of your silver is that it is antibacterial. Your amine compounds are for stabilization, and fluoride, like we always know, it reacts with the hydroxyapatite to form fluorapatite. So we go into the application of silver diamine fluoride. So the main problem with the silver diamine fluoride is the temporary staining of the soft tissue and your tongue or any area which comes into contact with your silver diamine fluoride. So in order to prevent that staining, what you could do is that you can protect your gingiva and mucosa using your Vaseline. Once you apply that, you can protect your soft tissues. After that, you nicely isolate the area, and then you can directly apply silver diamine fluoride onto your tooth surface. Then as time you should ensure that you have to keep your silver diamine fluoride around 1 to 3 minutes onto your tooth surface. And as time passes, you can see that your lesion is becoming more and more darker. And finally, once you probe, you will get a hard base or an arrested caries feel. So that is about your silver diamine fluoride. So silver diamine fluoride, it does not require any tooth preparation and it does not generate any kind of aerosols. So as I've already mentioned, the major problem with the silver diamine fluoride is the staining effect that it would result in. That is, even if you, especially when you're working on an anterior tooth, what happens is that because of this staining, it is unaesthetic. So whenever you're attempting a silver diamine fluoride, you should inform the parents that it is unaesthetic restoration. That is, because of the staining, even if you place a glass ionomer cement or a composite resin onto the tooth surface, here the black color could easily stand out. That is one main problem of STF. So in order to overcome that, various formulations are coming. You have certain reducing agents that can reduce the blackish color that is formed due to a silver diamine fluoride. So these are the commonly available silver diamond fluoride agents. So first one is the Advantage Arrest that is recommended by the American Dental Association. Then you have Rivastar and Fegamin, and ESDF is an Indian variant that is developed in our country. Now moving on to SMART, or the Silver Modified Atraumatic Restorative Treatment. So all of you remember our atraumatic restorative treatment. That is, you just excavate your caries and you directly place a glass ionomer cement onto the surface. So that is mentioned as an ARP. So a restoration is said to be a SMART restoration or a silver modified atraumatic restorative treatment. It is what? When you apply a silver diamond fluoride onto your tooth surface, as I've already mentioned, your caries will be becoming arrested. So, and on that arrested caries, if you place a glass ionomer cement, you call the restoration SMART. That is referred to as a silver modified atraumatic restorative treatment. Without any caries excavation, you can directly apply the silver diamond fluoride and then you restore it with glass ionomer cement. So this is another picture of your silver modified ART. So you can see you apply SDF onto the tooth surface and then you directly cement glass ionomers. Now moving on to the second set of materials, that is the chemomechanical caries removal. So as the name indicates, chemomechanical means there is a chemical component as well as a mechanical component. So what we do is that you place a chemical onto the tooth surface to dissolve the caries tissue, and mechanically you remove it with the help of a spoon excavator. So that is the mechanism of a chemomechanical caries removal. So this method can be easily done without any aerosol production. If your entry into a cavity is limited, in the second picture you can see the picture of an air rotor that is just to provide an access to your cavity. So what you do is that you apply a chemical agent onto your tooth surface, you wait for some time. This waiting period is one major disadvantage of the chemomechanical caries removal. So depending upon the agent used, sometimes you may even have to wait for 10 minutes for the entire caries tissue to dissolve. So the main disadvantage is its waiting period, and that depends upon the time of your agent. So once the caries tissue is dissolved, you can easily scrape it off with the help of a spoon excavator. So this is the picture of a CMCR. So what you do is that you do a rubber dam isolation. You place this chemomechanical caries removal agent and you try probing. You'll after some time you'll just do scoop it off with the help of a spoon excavator, and if still the base is found to be soft, you reapply it, you again wait for it, and then you scoop it out again until the tooth the caries in the tooth is almost arrested, and then you can continue restoration with either composite or resin modified glass ionomer cement. So there are two types of chemomechanical caries removal agents. That is, you have your sodium hypochlorite based agents as well as your enzyme based agents. So sodium hypochlorite based agents include Caridex and Carisol, and the enzyme based agents includes Papacari. So one main advantage of the enzyme based agents or your Papacari is that is its selective action. That is, it will act only on carious tissue and the healthy tissue is completely spared. So that is one major advantage of a chemomechanical caries removal agent, that is an enzyme based agent. It could be a papacari gel or a biosol, any agent you can use for this. Now we will move on to how we can treat a primary tooth or a young permanent tooth with deep caries lesion. So this is the clinical picture of your deep caries. The tooth shown is not a primary tooth; it is a premolar. So this is an evaluation of how you can evaluate the progression of your caries with on the basis of color. So you can see that a light yellow color shows that your lesion is actively progressing. A light brown color shows that your lesion is slowly progressing. A dark brown color shows that your lesion is slowly progressing or arrested. So this is how you identify the extent of your lesion and the progression of your lesion based on color. So you have to consider a lot of factors before you go on to the treatment of a deep caries in a primary tooth as well as a young permanent tooth. So in deep caries lesion, you have various treatment options. You have indirect pulp capping, you have direct pulp capping, and you have pulpotomy. So now we'll see how we will manage a carious tooth that is not involving the pulp in the posterior region. So our instrument of choice at this scenario is definitely spoon excavator. So you should always keep in mind that you should use a sharp spoon excavator. Now the second thing is that you should remove all tissue from the perimeter of the lesion until you reach a hard dentin. That is, from the periphery of the lesion, you scoop out all the soft carious tissue from the periphery of the lesion until you reach a hard dentin. Now the third thing is that you should remove only as much as tissue from the floor as it is required to allow adequate depth of the cavity. So when you use a spoon excavator, you should always keep in mind that you remove all the tissues from the perimeter of the lesion until you reach hard dentin, and then from the base of the cavity, you remove only as much as tissue that is required to allow the adequate depth of the cavity. And while excavation, if you feel that the patient is having any pain or it is difficult, you can use a slow speed micromotor handpiece without irrigation at this particular time. So the instructions regarding the use of micromotors I have already mentioned. So you make sure that when you're working on it, you would work only like that. After that, you can restore the tooth with a glass ionomer cement or a resin modified glass ionomer cement. So if you're going for a resin modified glass ionomer cement, use a finishing bar on a slow speed drill. And if you're working on a glass ionomer cement, you coat it with a Vaseline. Now moving on to the management of anterior restoration. So anterior restoration also, one thing you have to keep in mind is that you remove the carious tissue with a spoon excavator and then you place a resin modified glass ionomer cement. So one thing you have to keep in mind is that in toddlers and little children, what happens is that your treatment option should be always a non-restorative caries control. That is, you should give more preference to arresting the caries lesion as well as postponing of the restorations at this particular time period. So that is one thing which you need to know at this time. That is, whenever you get a decayed anterior tooth, the same management you use for the posterior tooth, that is, you excavate it with spoon excavator. When it comes to toddlers and children, you arrest the caries lesion and you try to postpone the restoration. So arresting caries lesion can be done with the help of diet counseling, fluoride toothpaste, your fluoride varnishes, your fluoride gels, SDF, etc. Now moving on to minimally invasive pulp therapy. So if the caries has extended and it has reached up to the pulp, you are forced to do any kind of endodontic procedures. So the first line of management in this COVID scenario is your symptomatic management. So these are the commonly prescribed pediatric drugs for the kids. So your most frequently used drug is your acetaminophen or your paracetamol, which is having less side effects when compared to any other drugs. Then you have ibuprofen, which you should be a little careful because of its bronchospasm that it could result in. Bronchoconstriction it could result in. Then you have mefenamic acid. Mefenamic acid, as such, it is not listed in the commonly used medications of your American Academy of Pediatric Dentistry, but still I'm mentioning the pediatric dose in here. Then in antibiotics, you have amoxicillin, then you have moxiclav, and if the patient is allergic to penicillin, you have clindamycin, azithromycin, and to get an anaerobic cover, you have also metronidazole. Now moving on to the minimally invasive pulp therapy again. So what you have to take care in your mind is that you should always treat under rubber dam isolation. So when it comes to a primary tooth, you should avoid pulpectomy in primary tooth, and prime importance should be given to extraction and placement of space maintainer. So that is one thing which you need to know. You treat under rubber dam, and pulpectomies are contraindicated, or rather you avoid doing pulpectomy in primary tooth at this particular time. Now, when you get a young permanent tooth, that is a permanent anterior tooth with a traumatic injury and a pulpal exposure. So in that case, you have two options. That is, you can either go ahead with a partial pulpotomy, or you can move ahead with a full pulpotomy. So what you do is that the partial pulpotomy, the decision on whether you go for a partial pulpotomy or a full pulpotomy is based on the size of the exposure site as well as the time after your injury. That is, if the patient is reporting within 1 week and if the exposure site is small, that is less than 4 millimeter, you can go ahead with a partial pulpotomy. So how do you do a partial pulpotomy? What you do is that you use a spoon excavator and then you remove about 2 to 3 mm of pulpal tissue. After that, you apply a pellet of sodium hypochlorite and a cotton just to arrest the bleeding. Then you can use the sealers or a barriers like an MTA, biodentine or calcium hydroxide, and finally seal it off with resin modified glass ionomer cement. So that is about the partial pulpotomy, which you do if the patient reports to you within 1 week of time and if the exposure site is small. Now moving on to full pulpotomy. You do a full pulpotomy when the patient presents to you later than 1 week and if the exposure site is large. So that is about your full pulpotomy. So how do you do is that when you have to go ahead with a full pulpotomy, definitely you need your access preparation. So when you need an access opening, you do it with a micromotor handpiece. You remove the entire coronal pulp, nicely irrigate your canals, that is the coronal portion you nicely irrigate it. Then you place a barrier like an MTA, biodentine or calcium hydroxide, and finally seal it off with resin modified glass ionomer cement. So regarding the traumatic injury, if the patient is reporting to you within 1 week and your exposure site is small, your treatment option is partial pulpotomy. And if the patient is reporting to you after 1 week and if the exposure site is large, your treatment option is full pulpotomy. Now, in the course of excavation of the caries, if unlikely or if you somehow iatrogenically you exposed a pulp tissue, your treatment option should be full pulpotomy. That is when you are working with your incisors or your molars, and while you are removing the caries tissue, if you iatrogenically expose the pulp, your treatment of choice should be full pulpotomy in the special COVID scenario. Now, the another clinical scenario that you could see is a permanent teeth with a diagnosis of irreversible pulpitis and no radiographic findings of infection. If there are no radiographic findings of infection, you can go ahead, that is, IDA has advised us to go ahead with full pulpotomy unless you find that the pulp is necrotic. So if the pulp is not necrotic, with the full pulpotomy, what we can achieve is that the remaining pulp will heal as long as the hemorrhage is controlled and you apply a biotight seal. That is a bacteria tight seal. If you could obtain a bacteria tight seal, the remaining pulp will heal. But you always keep in mind, whenever you're doing a pulpotomy on a permanent teeth, you should keep in mind that you might need to re-enter for a future RCT if the signs and symptoms of pulpal necrosis appear. Now, another scenario is a teeth with a necrotic pulp and the presence of a periapical lesion. If there is a periapical lesion, you don't have any other choice. Your only treatment option is root canal treatment. So when you need to do an access opening, as we have already mentioned, use a micromotor for access opening. Then you nicely irrigate the canal. You place a calcium hydroxide dressing, and One thing you have to keep in mind is that you postpone your obturation. Your obturation can be performed after a few months. In this current COVID scenario, the objective of a therapy is to reduce the symptom, to arrest the progression of the disease, and to allow the healing of the periapical lesion. So you should make sure that you obturate the case, you recall the patient at a later period for obturation, because you are supposed to, or you are advised to do only emergency management at this particular time. Now moving on to post-endodontic restorations. So after your endodontic treatment is finished, your next thing is definitely your post-endodontic restorations. So in this COVID scenario, as I've already mentioned, the fabrication of the zirconia crowns or full crowns are completely avoided, because it will require the use of a high-speed air rotors. And it requires extensive tooth reduction. So you can practice. You have for the primary tooth as well as for the young permanent tooth, you have another option called the stainless steel crowns. So the conventional stainless steel crown, as you all know, require tooth reduction of around 1.5 to 2 mm occlusally. Then you have proximal slicing and all. But in another method of stainless steel crown called the Hall technique, you directly cement the crown without any tooth preparation. That is, without any tooth preparation, you can directly cement the stainless steel crown. The only problem that it could result is the height points, which would be corrected within the initial few days alone. And the occlusal adjustments will be made automatically. So if the patient is insisting on an aesthetic restoration, you can do a stainless steel crown with Hall technique now, which could be later replaced at a later date. Moving on to the oral radiological procedures. So most of us will be having our RBG sensors or your PSP sensors or your conventional IOPA radiographic films. So when you're working with an X-ray films at this particular time, you should ensure that you cover your RBG sensor or your PSP receptor or your IOPA film with a plastic sleeve or a plastic cover. So normally, while you're taking the X-ray, not for IUPS, for your RVG and PSP sensors, you use a single plastic sleeve. So in this special COVID scenario, you use 3 plastic sleeves. The outermost layer sleeve is removed by the patient and you dispose it. The second layer, you ask your assistant to remove it. And the third layer, that is directly in contact with your sensor, you only remove it and you place it into your machine. So that is one thing which you need to take care of. So whenever you're working with your conventional IOPA films or your RBG films or your PSP receptors, you ensure that you place 3 plastic sleeves or coverings on your receptor or your IOPA film. Now moving on to the aesthetic procedures. So as you all know, aesthetic treatment is not listed in your emergency management at this particular COVID scenario, but if they are insisting or if we are forced to do an aesthetic procedure, you always make sure that you work under rubber dam isolation. And whenever you get a class 4 restoration with a chipped out tooth, you need a proper beveling of your composite so that enhance the bonding of the composite, which you achieve it with the help of a micromotor handpiece. So direct composite restorations are one restoration which you can easily do with minimal aerosol generation. Now, diastema closure can be performed without much of an aerosol generation and tooth preparation. Now moving on to the periodontal procedures. So as we all know, ultrasonic scaler, its use should be avoided because it generates the maximum amount of aerosol. So at this particular scenario, we are advised to use only hand instruments for your scaling purpose, and you make sure that you make your patient or your child to do an intermittent rinsing with povidone iodine or chlorhexidine or any antiseptic agent every 10 minutes. So you do only hand scaling at this time with intermittent antiseptic mouth rinsing. Now about the pediatric surgical procedures. So oral surgical procedures, your exodontia, you can do it with minimal aerosol generation, but you need to use a pre-operative mouth rinse before doing an extraction. Then you scrub intraorally with povidone iodine. Local anesthesia can be administered without causing any generation of aerosols, and you advise the patient strictly not to spit after your procedure. So these are the things which you do in your oral surgical part. Now, moving on to the last session, that is your orthodontic procedure. So, in a child, you can see you generally give removable appliances as well as fixed appliances. So, under removable appliance, you have your space maintainers, your habit breaking appliances, your functional and non-functional space maintainers, your appliances for your minor corrections, that is appliances with set spring, finger springs, etc. Then in the fixed appliance session, you have your fixed space maintainers, fixed habit breaking appliances, then your conventional fixed appliance therapy. So actually, orthodontics is one specialty which generates minimal aerosols, except for some procedures. So orthodontic practice can be done at a relatively lesser risk. But you should keep in mind that only orthodontic listed emergency is a pain and trauma that is occurring due to a broken wire or a broken appliance. So, whenever possible, you should try to postpone your appointments. You should try to postpone your orthodontic appointments, like your evaluation or a recall appointments of your oral screen or your recall appointment for your space maintenance. Whenever possible, you should try to make it at a later date. And if you need to do any kind of cementation or your removal of certain appliances like your transpalatal arch, nanspalatal arch, or your RME, you don't use a three-way syringe. As I've already mentioned, three-way syringe will generate a large number of aerosol. So even if you are using a three-way syringe, you ensure that you reduce the pressure to a minimum. And generally, rather than using a three-way syringe, you can go for a chip blower to gently dry the tooth surface and a hand scaler to remove the excess cement. So another condition that you could see is the adjustment of your removable appliances like your splints, aligners, and retainers. So you should ask your patient to brush their appliance thoroughly and before entering your procedure room, and use a soak it in povidone iodine prior to adjustment. So before doing any adjustments on your acrylic appliances, you ensure that you soak it in povidone iodine. Now, about your acrylic appliance disinfection, the preferred agents are again povidone iodine, 1% sodium hypochlorite. And you should avoid storing your processes in a disinfectant before insertion. But what you do is that you generally store your acrylic items in diluted mouthwash until it is inserted after your disinfection. Moving on to the impression trays. Plastic trays are avoided at this time and you prefer metallic trays. Once you use a metal tray, the main advantage of a metal tray is that they are autoclavable. So that is the main advantage of a metal tray. Custom made trays are also advised because you will discard it soon after the use. So whenever you need to take an impression, you avoid plastic tray and you prefer only metallic trays. Now, regarding the impression disinfection, immersion is always better than spraying because it reduces the chance of an aerosol production. And the two commonly used impression materials is your alginate and elastomeric impression, which are disinfected with the help of 1% sodium hypochlorite solution or any glutaraldehyde based or your quaternary ammonium compounds. So it is time for me to summarize. And as I summarize towards an aerosol-free dentistry, what I would like to suggest is that your treatment protocol, it varies depending upon the type of caries you have. If the caries is a small caries or an incipient lesion, you have options like your use of remineralizing agents. It might be either a fluoride agents or a non-fluoridated agent. Then you have other methods like resin infiltration method, which also do not generate any aerosol, much of aerosol contamination. Now, as we go on from incipient lesion to pit and fissure caries, yes, you are advised to use a pit and fissure sealant without much of an aerosol generation. And when it comes to a deep caries, when it comes to a moderative caries lesion, a conservative management approach should be with the help of a spoon excavator. So, as I've already mentioned, when you're using a spoon excavator, you take off all the caries from the periphery or perimeter of the lesion, and from the base of the lesion, you remove only as that much is necessary to maintain the width of your cavity, depth of your cavity. So that is how you should use a spoon excavator. Then your second option is your silver diamine fluoride. That can be used to arrest caries lesion in a geriatric as well as in pediatric patient. So after application of silver diamond fluoride, if you go ahead with restoration with the GIC, you call the restoration a smart restoration. Now, moving on to the minimally invasive pulpal therapy. So you have partial pulpotomies and full pulpotomies. So the decision is based upon your emergency scenario. That is the time after trauma. If the patient reports back to you within 1 week and if your exposure site is small, then you go for a partial pulpotomy. But if the patient is returning back to you after 1 week and the exposure site is large, you have to go for a full pulpotomy. And if the pulp is necrotic, you have no other option left. You have to do a root canal treatment under rubber dam isolation, and you use a micromotor handpiece without irrigation with intermittent breaks to reduce the surface temperature. One thing you should take care when you're doing a root canal treatment is that you postpone the obturation. In this emergency scenario, you do only the emergency treatment part. Now, moving on to the post-endodontic restoration, full coverage crowns are contraindicated, and stainless steel crowns with Hall technique, that is with minimal preparation, can be easily carried out. Now, regarding your periodontal procedures, you go ahead with only hand instrumentation, and the use of ultrasonic scalers are contraindicated. Regarding radiographic procedures, OPGs are advised, and if you are working with your IOPA films, that is with the help of a conventional IOPA film or a PSP or an RBG sensor, you should ensure that you cover your film or your receptor with 3 layers of disposable plastic sleeves. Now, oral surgical procedure, your extractions and your abscess drainage can be done following the conventional protocols and with minimal aerosol generation. You always advise a pre-procedural rinse as well as an intraoral scrubbing with povidone iodine. Now, regarding your orthodontic aspect, orthodontic procedures, they generate minimal of aerosol production except a few procedures. And the listed orthodontic emergency is a trauma or a trauma caused due to a broken wire or a broken appliances. So, and even if you have to do any tooth drying or any tooth appliance corrections, you should try to postpone whichever appointments which we can postpone, like an oral screen review or a review of your space maintenance. If possible, you should try to postpone your appointment and in order to dry your teeth rather than using a three-way syringe, you prefer the use of a chip blower because it generates minimal aerosols. So as I come to the end of my presentation, see, you know that each kid is unique and each kid is different. And you would have seen all these cute expressions on them, like what you see here. But once you start to explain your air water procedures to them, probably however simpler way you try to explain it to them, that is, you might be explaining it so beautifully, just like I'm going to bath your teeth or anything like that. But what the child perceive would be something that is seen in your second picture. And ultimately, your child would end up like this, right? So in this special COVID scenario, when we are wearing our personal protective equipments, the face shields, N95 mask and all, in this particular type behavior management, definitely there would be a compromise in behavior management while you are working on. But however uncooperative the child was, that is, even if you got a extremely screaming child showing a lot of temper tantrums, if you could make the child smile, or if you could make the child free of fear from you, that is, in this scenario, as we all know, we cannot go ahead with the drilling preparation. So once you're following the no drilling no filling protocol, this particular time you can easily become a kid's favorite dentist. And as I've said, however uncooperative the child was, whatever things they have thrown at you, if you could make the child smile while the patient is leaving your clinic, if you could make them wave at you with some kind of cute gestures, or any cute kind of emotions or gifts, that is the best thing that could ever happen to you. So with that, I'm concluding with my presentation. So I would like to thank all of you who have been listening to me. Special thanks to the Women's Dental Council of IDA Malabar, Dr. Shebi, Dr. Samira, and then to the President of IDA Malabar, Dr. Shaju Mandoli, Dr. Navjeera Jeman, our Secretary of IDA Malabar. Thank you for this wonderful platform and opportunity. So let's all fight together against this COVID infection. And we should always ensure that nothing wrong could happen from our side to that could result in the spread of the infection. With that, I come to the end of the presentation. Thank you all for listening to me patiently. Thank you, IDA Malabar, once again.